Sure. Um, but okay, I mean, for the skin, I think the problem with physical assessment, regardless of the chapter, is that there's a lot of content, and I think sometimes you feel like you have to memorize everything, and that could be true, or it could feel like that's the case, but it's really not. They're really looking to see, like, your understanding of the physical assessment and, like, what you do during it. So regardless of, like, what chapter you're doing, you need to focus on, like, the basics. So, like, for example, when you're looking at the skin, you need to understand that there's different levels of the skin, right? And you have the epidermis, so we're talking about the outer layer, and we're talking about it's our first line of defense. So we know that if there's a problem with this layer, we have risk for infections, and that can be really bad. Um, and there's different types of cells here, right? We have the melanocytes for like our pigmentation. We have like Merkel cells and Langerhans cells, and they have specialized roles too. But um, regardless, they're not going to really test you as much on the cells. They're going to ask you, okay, like when you're looking at the skin, right? What would be the outermost layer and what does the skin do, right? So if there's a problem with, pain or touch, that would be more in the epidermis. We're looking for temperature problems. That would be where a problem would lie, would be in the epidermis. But the dermis is what supports it. So if there's a problem with circulation, we're talking about the dermis. If there's a problem with the sweat glands, that's what we're looking for, which is that second layer, the layer that's underneath the epidermis. And then we have a subcutaneous layer, which helps with fat and connective tissue. So this can also help provide cushioning and temperature. So this could also be indicative of like a temperature issue. And that's kind of how I want you to think about physical assessment. I don't want you to think about all of the nitty-gritty. Like, I want you to think about, okay, like, what does this do? Like, why is this system important? Like, what am I looking for? So, for example, right, when you're looking at the skin, you're thinking of, okay, I'm looking for, is there pigmentation issues, right? Is the temperature equal bilaterally, right? If I use the back of my hand to, palpate one arm and I use the back of my hand to palpate the other, the temperature should be equal. The pigmentation should be equal. That's the things that you're looking for. Same thing with hair, right? Hair is important because when hair is on your skin, you should have hair on your skin because that indicates good perfusion, good circulatory system. So if there's hair, that's good. They should have hair on their body. It also protects with other things, right? Like it provides insulation, it has sensory and nervous system stimulation, but regardless, right? They play an important role. It tells us about circulation, tells us about sweat glands, and it also helps us with touch. So as you're palpating someone's skin and you're going, okay, I'm starting with the left arm and then I go to the right arm, if they're saying, hey, I don't really feel sensation here, that's a problem. For the nails, yes, we have the nail bed. They're gonna want to know. I know for Dr. Balkan, she did ask about the nail bed in terms of what the angle should be, and I believe I'm just gonna double check, or someone can correct me. That's totally fine because I haven't done this in a little while. Um, but it should be, I believe, 180 degrees should be the nail. It should be less than 180 degrees. Um, and they're gonna ask you what should the nail look like. So if you look at your own nail, you could simply say, okay, like a normal nail, right? It should have like a pinkish tint to it, right? The angle of the nail should be less than 180. You might not know that from the top of your head, but it shouldn't be straight, right? Like a nail shouldn't be straight. There should be some little curvature towards it. If it's not, there's a problem, right? Um, so that's what you're looking for. If it's white or if it's blue, that's a sign of poor perfusion. That's what they're testing you on. It's not as much about um, all of these like glands. It's not anatomy and physiology. This is what you're looking for, right? So when you're looking at the nails, what should I be thinking about? The coloring, right? Um, things like that. It should be pink, it shouldn't be blue, it shouldn't be white. White would be a sign of hypoxia, and blue would be a sign of hypoxemia, which hypoxia means lack of oxygen to the tissues, whereas hypoxemia is a lack of blood circulating in the cells, in those blood cells. Okay, so that's why it turns blue. And that's not good. That's also a late sign of hypoxia. They're going to ask you about glands, particularly right when we're thinking about the skin. We know that it's normal to produce sweat. We need sweat for temperature. So we're looking at what sorts of glands do that, right? So we have the exocrine glands, right, which is our sweat glands, but then we have apocrine glands, which is more or less for our body odor. So knowing the difference between that is definitely something they're going to ask you. Okay. I'm just trying to like skim through this. For skin, another thing is that when you age, your skin loses elastin, it loses collagen, it loses like the tightness of it. So if you feel your own skin, right, as a younger person, it's going to be tighter, right? If you pull on your skin, it's going to go back down. For an older person, that's not the case. So we call that skin turgor, that decreases, right? So there's more of a risk of skin breakdown because they don't have all that fat. They don't have the same sorts of elastin, collagen, subcutaneous tissue that we have. So the skin's more wrinkly and things like that. And because there's decreased melanin, right, where it helps us, that gives us our skin pigmentation, we have to worry about, okay, burns. Those are the things that they want you to think about. Always need to consider culture. Um, there's birthmarks, tattoos, body piercings. That could also affect how you do a health assessment in terms of looking for things, right? If their arms are tattooed, you'd want to look for temperature, but it might not help you with skin pigmentation, right? So just think about that. Um, okay. So, like I said, I'm just skimming through this to give you like the main ideas because I know everybody's on different things. Um, Also, right, we need to know that in a lot of cases, right, when we're looking at the skin, it's not really emergent. But if we're noticing, a patient's coming in with a lot of cuts, a lot of bruises, okay, we need to look at that. If there's a lot of lacerations, right, this, especially for like an older patient, we could be thinking about abuse or things and things like that. Clots, right, burns, if they have that, that could also be a problem that could lead them to go into shock. So knowing what the skin looks like and making sure the skin is protected from injury is very important. So, always you got to get your subjective and objective data. Subjective data is what they tell you. So, what their past medical history is, they'll usually tell you that, like, oh, I was diagnosed with hypertension, or I have high blood pressure and I have a history of high cholesterol. Oh, I don't really exercise a lot, but I like to bike ride every now and then. That's like subjective data. Okay, so we want to find all that out. Their medications, their family history. This is every assessment, regardless of skin. Even it repeats all the time. So knowing what subjective data is, which is usually your health history, and your objective data, which is your physical assessment, you're always going to do that for every system. Now, also think about when you're talking about these systems and you're studying them, those are considered focus assessments. You're learning how to assess for a particular system. So keep that in mind. And some things also to consider while you're doing an assessment after you're getting your subjective data. If they tell you, hey, I've noticed a lot of nail changes, hair loss, increased bruises, moles that were appearing that were never there, non-healing cuts and bruises, those can be signs of cancer, right? So we just have to be careful. Hair loss can be indicative of a circulatory issue or another issue. So, different things. So that's why we really need to get a good subjective history from them by asking them questions and as well as allowing them to tell us things about themselves. Also, something commonly asked for the skin is UV radiation, right? That they shouldn't be exposed to that in excessive amounts. Um, and ask them about their sun exposure and the importance of wearing sunblock. Um, other things, right? Pruritus, rashes, things like that. Those are things that we want to look at. Those could be common depending on what they have, right? If they have eczema, which is dryness of the skin, they could have rashes. But if they don't have that and they said, oh, I started taking a new medication and now they're having a rash, they might be having an allergic reaction. That's why we're looking to see what's going on with our patients. Um, Let me see what else is here. Okay. So right, for assessment, we do inspection, palpation, percussion, auscultation, right? That's the order. Um, for the skin, there's not necessarily a need to sort of auscultate because you're not auscultating the skin. You're going to maybe palpate for pulses, right? And things like that, but you're not going to really auscultate the skin. It's more about inspections and palpating, right? You want to inspect the hair, you want to palpate the skin. We talked about temperatures, things like that. We said looking at the hair, toenails, pressure points, right? Especially for that older population. That's our bony prominences there, like our shoulders, our elbows, our knees, right? Your like your hips. That's where you could get pressure injuries. So they're definitely going to ask you about things like that. In terms of, okay, if you see a pressure injury, how, based on the presenting either picture or the information they give you, what stage is that? So you need to know that. Always, they might even ask you as like a general question like, hey, how do you set up a room? And it doesn't have to just be for skin. This is any assessment, right? You should have a warm room, right? Shouldn't be the temperature should be, good. It shouldn't be cold because cold can cause vasoconstriction, or meaning the blood vessels constrict a lot, and that's not really good either. That could lead to poor perfusion, right? We want privacy and comfort and cultural considerations. We want examination gowns, measuring tape, adequate lights, magnifying glasses if we need to like see something on the skin more clearly. But like I said, our main focus is inspection, looking at it, and touching. And these are some of the things that we're looking for. Um, I was never really asked too much about growths and lesions. I would look some of them over, but some common like ones that they'll talk about was I already mentioned cyanosis, which is that bluish color. That's usually you could see that on your fingernails, your toes, your mouth, your lips, things like that. It's like blue, right? Imagine like when you come out of the pool and you're really cold and maybe your parents used to say, "Oh, your lips are blue." Well, that's cyanosis, right? Lack of perfusion. Um, Arrhythmia is like redness. Okay. It's another way of saying red. It's increased blood flow. That's why you turn red. Like when you go to the gym or you work out or you do something strenuous and you turn red, that's called arrhythmia. Um, there's some other ones like carotenemia, which it's not really harmful, but it's usually a dietary problem. So you should expect your palm of your hands are usually pink. That means perfusion, but it might not be. It might look like a yellowish color. So, and it's actually because a diet and high of carrots and other yellow vegetables or fruits can cause that, but it's not too much of a concern. Now, another thing when we're talking about skin and we're inspecting, right? The eyes, that white part, the sclera, can turn yellow. That's indicative of jaundice, which means there could be a liver issue. So, what happens is that jaundice is caused by something called hemolysis of red blood cells, which means hemo means blood, lysis means breakdown. So, the breakdown of red blood cells, red blood cells from A and P have bilirubin. So the bilirubin gets released when those red blood cells break. And because there's too much of it, it causes the yellowing of the skin. And that could also be because the liver is producing too much bilirubin and causing yellowing. So they're definitely going to ask you what is jaundice indicative of. Um, and there's other like conditions like which you'll see. I don't know if it's the right chart, but it's going to be table 9-2. In the this is chapter 11. So I guess it's somewhere in 11, but go to that, know what like the one that says skin changes and local changes. Another common one is vitiligo, which is like people who have like different pigmentations on their hands, face, and feet. So let's just say they have like patches of like white and brown skin all over their body. That's what this is called. And it's usually something that's hereditary, and that's something they usually ask about. What is vitiligo? I'm not sure if I'm saying it right, but yeah. So like I said, look at that chart. Those are just some common ones that I wanted to point out to you. Um, Definitely, edema is something you'll go over in this chapter. Just know that there's pitting and non-pitting. Non-pitting means that if you press it, it doesn't make a little indent, and if you touch it and it does make an indent, it's pitting. And some other things that they will ask you about is the different types of lesions in terms of um, how to identify what is a papule, what is a nodule, what is a cyst. You'll have to know like those definitions, and that's in one of your slides. So that would be primary skin lesions that you want to look out for, I would definitely say, and not every single one, but just review um, some of the secondary ones. Just read through the charts because they're not going to ask you about all of them, but especially the primary lesions, they're very popular. So you want to make sure that you know those. And they're going to go right to your charts for that. That's why I mentioned going to the charts. And yeah, otherwise than that, like I said, it's going to be looking at those things as well as your pressure injuries. You need to know how to identify each. So I know there's no pictures here, but like stage 1 of a pressure injury means that the skin's still intact and it's red. Stage 2 means that there's partial loss of the skin.
Hold
So
on, I'm
now the
sorry. Can you
skin,
just slow down
hmm?
1 second so I can write that down?
Yes, no, that's okay. Yeah, stop me if I'm going too fast. Um, so yeah, stage 1 is a pressure injury means that there's lack of blood flow. And I was talking about bony prominences before, like your elbows, your shoulders, or like bony prominences, especially in the elderly. You usually see risk factors such as, right, not moving a lot. So if they're on bed rest, they're at risk for pressure ulcers or pressure injuries. If they're having a decreased sensation or decreased perfusion, but usually you see this from immobility or urinary incontinence, which means they go a lot. Fecal or urine incontinence, they just go a lot. Or someone who has fractures, right? Because let's just say it's immobilized, right? It still relates to the idea of mobility. They can't move it for a long period of time. They're at risk for pressure injuries. So, stage 1 means that the skin's still intact, but it's usually red. In stage 2, it's more or less that we have the skin's not intact anymore. It's going to be red. You're going to start seeing some of the dermis here. Okay, but nothing more than that. Just the skin's not intact, and you start to see the dermis, which we call partial thickness skin loss. Stage 3 is when we have full thickness skin loss. That's usually how I say those terms because that's usually how they refer to them. And so in this, it's like every stage adds on to the previous one. So we still have more now. The dermis could be exposed still, but even more than that, we get into those deeper levels like the fat. Okay, so we start seeing fat and potentially those wound edges are more like rolled. Um, and it's not really good. Okay, so we get more into the fat when we get into stage 3. By stage 4, we have full thickness skin and tissue loss. So now, in addition to the fat, right now we're getting into the muscle, bone, ligaments, cartilage. This wound is just getting deeper and deeper. And then we have some other ones. We have unstageable pressure injuries, which is it's really hard to tell, and that's because we have something called SLAW or SCAR. Now we see SLAW and SCAR potentially in stage 4, but if it obstructs the view of the ulcer, meaning it's hard to just identify because there's so much of this like yellowy black stuff on it. We call that unstageable. So we know that it's deeper, right? It's in that like stage 4 area. It's very deep. We just can't see how deep it is. And the last one is they call it a deep tissue pressure injury, which is typically the skin can be intact or non-intact. And it's usually non-blanchable, which means that if you press on it, the redness isn't going to go away. And it's usually a deep red, purple, blue discoloration. And that's what a deep tissue pressure injury is. Because the skin may or may not be intact, we really don't know, how deep this could go. So it's really hard to tell, but it's really characterized by like a purple red color. I mentioned that so you have that down now, and you look at that. But yeah, when they mention charts, especially Dr. Balkan, like if she's mentioning these charts, hair findings, look at them. And if they're in your slides, regardless of the professor, look at them, because these things that you'll see in these charts about different conditions of the nail, they definitely ask you about them. So just look at them, read them over, and yeah. So those are like really common things. Um, and the last thing that I want to point out is that with hair, there's something called alopecia, which is when you have hair loss. And there's something called trichomania, which is hair loss, but from pulling at your hair. So there's like broken pieces of hair, and you usually see this in people who have anxiety. Um, but yeah, so know those charts, read them over. I tried to give you a summary, but like I said, think about the main picture, right? Like, what am I looking for? Why are these things so important? And you'll also have to know, they definitely ask 1 or 2 questions on the ABC box, which is basically how to assess for melanoma. It's a very common cancer that people can get. And basically, the ABCs is for a mole. We're looking for A stands for, is it asymmetrical? The B stands for, is it having irregular borders? C is for, hey, if the color changes. The D is for if the diameter of that mole is greater than 6 millimeters. And E, if it's evolving or changing rapidly in some way, size, shape, color, whatever. That's how you know if a person has melanoma. And you do that by telling people, hey, right, you need to perform a self-exam. You need to look at yourself in the mirror, and you need to see yourself all the time and make sure, are you seeing anything? Are you noticing any changes? Okay. Especially in that like older population. Any questions on that for the skin or hair and nails? No, I don't. Okay. So, like I said, go over those charts, read them over. I tried to mention some things that I know I've seen. Um, but yeah, is there any questions on either this or another slide or a different topic? Because I can go into something else too, and I could explain whatever you want while I'm here.
But I know I have a therapeutics, like our first therapeutics lecture quiz on Friday, and it's in like 5 different chapters. Um, but yeah, I don't know.
Do you have
Well,
Patricia?
I have Mary Sedman. I would say Sedman.
Oh yeah, she didn't tell us what chapter you're in her morning class.
Yeah, on Friday.
Yeah, she didn't send an email yet with the chapters. Did you get it?
Yeah, I think she made an announcement with, I'll tell you right now what chapters. There's like at least 4 different chapters. I'll tell you guys right
That's wild
now.
because she hasn't gone over anything.
Yeah, that's what I'm saying. Like, I feel like if we were to study anything, I think it'd be a bit smarter to study this. Because at first I was like, oh, I don't think it was gonna be that hard, but I just didn't know it was gonna be on this many chapters. But I'll tell you what chapters right now. I just
Sure,
have to
thank
find
you.
it. Mhm.
Is that something you'd want to go over? Therapeutics, like the topics, like certain things from them?
Yeah, she posted it.
Yes.
She posted it, I think, yesterday. It says Friday quiz, February 16th. The chapters covered are 1, 4, 9, 10, 25, 32, and 33.
Mm. Well, I have no idea what that means. So if you want to
Oh
tell
wait,
me,
that's right, because I have seminar
I
with
just
her
wanted
because
to
the
show.
classes run concurrently. But okay, I'm gonna study those anyway.
Yeah, but I was just saying that like it's a lot of and she was like plus anything we covered in class, but I don't know if it's different with FK and this class. Like I don't know if it's the same
The
Well,
topics.
I
chapter that
have
you
Stedman
mentioned,
on Friday morning, but it runs, I think, therapeutics and then seminar. But I think for seminar, she's gonna do this. I don't know. It might be the same.
it's the same because the chapters that she mentioned are for seminar as well, like the 1, 4 something, whatever, those are seminar. So if you have seminar with her, then I guess that will be separate. So I guess just study everything.
And it's the Jensen or the Taylor.
It's Taylor. Yeah, Taylor, because seminar goes for Taylor as well. They use the same fundamentals on book.
but
Yeah,
I
but
can go over those
is
stuff.
that's what I was saying. Is it better like to study the slides that she posted that she went over in class, or would it be better to study with like whatever's on course point and like the prep you? Like I don't
For
know if you
therapeutic?
study. Yeah. So like I mean like for most classes, because like I don't know which like what's better to spend more time studying.
So for all the quizzes that I've had already, I've only had them for physical assessment, but everything is based off of prep view.
Okay. Okay. 'Cause I've only had one quiz so far. So
Yeah, I think PrepU is good. It
They
definitely.
want us to use prep view and to get a mastery of 5, 6, so that way we get used to the questions because they're NCLEX like questions.
Also use ATI, that helps a lot too.
Yeah, definitely. I think PrepU is good. And ATI. PrepU, I never at least really saw her. Vulcan doesn't take PrepU questions, but the concepts that you get from them are what they're gonna test you on, like the things that they see. So, I also think like PrepU has a teacher's mode where it has like a set of different questions that are like similar to the ones that PrepU has. So if you understand the concepts from that, it should be similar on your exam. But is there any questions about anything like from those topics that I could maybe help explain to you?
Is it okay if I could send you PowerPoint? It's
Mm,
basically the same thing as the physical assessment, but it's the therapeutics one, like skin integrity with wound care.
okay.
Can I get your email? I don't think I have it.
Yeah, I typed it into the chat.
Oh, you did? Okay. Okay, thank you. I sent it. I think it was sent.
I didn't get anything yet. It might take a second or two. It went through, right? Like it said sent, because I don't see it yet.
Yeah, let me send it again.
Yeah, because I didn't get anything.
For some reason, it's not sending through my computer, but it's fine.
Okay, it's okay.
You
We could
could check.
definitely like. Yeah, I don't know. I don't know why I'm not getting it. Um, but you said that the chapter is on wound care?
Yeah, like wound care, skin integrity. Basically, like the what we was talking about recently about the skin, hair, and nails, but mostly like wound care.
Well,
Okay. Yeah, I don't know why I'm not getting it. If someone else wants to try sending it to me, if it's the same one, you could
I'm
try.
pretty sure all professors have the same like what's it called? The same PowerPoint.
who are you trying to send?
Hmm?
It's at the what's it called? It's 33.
33?
Mm-hmm. For therapeutics. It will say 32, but yeah, just it's 32.
Now to my computer and I'll try sending it. It should pop up.
I got it. I don't know why the other one didn't go through. But I got this one. So you all can see this new one.
Yes. Yeah,
Yes.
that's
Oh wow, there's 123 slides. I'm not going to be able to get through 123 slides in 15 minutes, but I will highlight key points because this is a lot. Okay. So basically, we already spoke about with the skin, right? Problems that can affect it would be immobility, right? Nutritional issues, right? Um, as well as if they have problems with perfusion, all of that can affect the skin, as well as if they have any sort of illnesses, right? And an example of like an underlying illness that could affect the skin would be like peripheral arterial disease, which is where I was mentioning before, like, oh, it's really important to have like hair on your body because that signifies like perfusion. Well, in peripheral arterial disease, because there's a problem with the arterial perfusion, they actually don't have hair. And because there's lack of perfusion, they're at risk for like ulcerations. So that is why we need a good, blood flow. We need good mobility, and we need to protect the skin as well as make sure we're fully nourished and fully hydrated so the skin has what it needs. Definitely know that as you age, right, there's more problems in terms of like the skin integrity and circulation as you get older. Whereas even when you're younger, like younger than 2, the skin is thinner and weaker. So that also becomes a problem. Okay. Let's see. So other things, like I said, older people remember thin, not elastic skin, so they're more prone for injuries, as well as someone who's dehydrated has a bigger risk for injuries, as well as people who are also obese, because imagine you have like either not enough skin, so you don't have enough muscle and fat, or you have too much fat, right? All of that could impede circulation and could affect your skin's integrity. So, there's intentional, I've never seen them ask any of that, but obviously intentional injuries would be someone trying to inflict pain, and unintentional would be like an accident or something. Trying to get to like the nursing stuff. So, regardless, I don't know if they're going to ask you about the types of wounds. I never was asked the types of wounds, so I'm going to skip over that for now. I would just know that hematoma is another way of saying a bruise, where blood pools under the skin. That's what a bruise is. Okay. So I want to get into the nursing stuff with you. So, now let's just say we're talking about acute or chronic. I always want you to know that with acute and chronic, when it comes to nursing and it comes to priorities, it's always acute first and then chronic second, because acute means something temporary, which is more problematic than someone who has something that's chronic or more long term. So, an acute wound would be something that occurred in the last 4 to 6 weeks, like a surgical wound, a bite, a burn, an abrasion, a traumatic wound. Those are examples of acute wounds. And, depending on how bad it is, right, it might need minimal intervention. Like if you cut your skin, right, like a paper cut, obviously just a band-aid, that's an acute wound, right? But let's just say a surgical wound, that might need more cleaning, more, antimicrobial therapy, things like that. Chronic wounds are something that we have for longer than 6 weeks, and usually see this in people who have like diabetes, obesity, smoking, AIDS, or chemotherapy. That's because they have delayed wound healing, so they cannot heal properly compared to someone who doesn't have those issues. So, as I mentioned before, people who have problems with perfusion, which is delayed wound healing, right, is going to cause potentially pressure sores or ulcerations, okay? So, it could be a vascular problem, a blood problem, or a nerve issue, because we know how the nerves are very important in terms of helping things circulate, helping get perfusion, okay? So, with a chronic wound, we have wound dressings, maybe antimicrobial agents. The importance of footwear, always keeping things on your feet, is something they typically ask on your exams. Right, as well as, education on how to prevent injuries, which is what, right? Protecting yourself from harm, wearing shoes, right? If you are immobile, increase your mobility and make sure to move every 2 hours. As a nurse, if you have pressure injuries or a patient is bedridden or they're not moving a lot, they're at risk for pressure injuries. So nursing interventions are, hey, well, you know what? We need to move this patient every 2 hours to make sure that they don't develop a pressure injury. Okay. As well as when you turn them, you could put pillows or cushions on their sides to alleviate pressure, especially if they have a sore. So if they have a sore on their shoulder, we don't want them to continue laying on that pressure injury because it's going to continue to prevent perfusion to that injury. So what we'll do is we'll put like a little pillow underneath that shoulder so that there's pressure alleviated off of it and blood flow can circulate. For venous leg ulcers, which is a problem where the blood is going towards the heart, right? And since this isn't oxygenated blood, this is an ulcer from poor perfusion of the veins, which is carrying a lot of that CO2. So we usually do compression therapy as a way to mitigate that, because the problem is that the blood, it's not being able to go back up to the heart as easily as it could. So we have more CO2. So that compression therapy helps push it back up to where it needs to go. So we already talked about ulcers, so I'm not going to get into that. But remember, our goal is to keep the skin intact, make sure there's adequate blood flow. We want to promote normal healing, or as normal as we can, especially if it's like a traumatic injury, and hand hygiene. Doesn't matter the exam. The best thing that you can do for infection prevention is hand hygiene. That's the answer. That's always the answer. I've never seen it be anything else. And we already talked about the importance of like nutrition, food, things like this. So, I've also never been asked on a therapeutic exam or fundamental exam about the phases of wound healing, but you should know it because it's going to come up somewhere. If it is on this exam, good, because then we're going to go over it now. But I was never tested in this particular class on this. But the main idea is that you get a cut, right? And you bleed. And then what happens is that your body initiates an inflammatory response, and that causes clots to form. When those clots form, that helps stop the bleeding. Eventually, the scabs can form. And then we get into this proliferative phase where, that clotting helps stop the bleeding, and then it just shrinks smaller and smaller from the big wound size that it was to an even smaller one. And then we have a remodeling phase where basically the skin is able to fix itself up. That's why when you cut yourself, right, after it scabs, your skin's able to go back to normal depending on the degree of it, because your body has natural mechanisms to heal. So, like I said, I've never been tested on how it heals or what causes it, so I'm not gonna get into that. I've never seen that on NCLEX so far. But okay, so let me see. I'm trying to get through some of this stuff because there's definitely a lot here, but I'm not gonna get into all of the phases because I've never seen that, like I said, me personally being asked on an exam. But I've been asked, okay, what can affect wound healing? We already talked about certain types of comorbidities or illnesses that can do that, right? Is there a lot of pressure being exerted, right? That could block blood flow. Are they dehydrated or overhydrated? That can affect wound healing. How bad is the trauma, right? Edema, we talked about, that's fluid building up. That can also affect how a wound heals, right? Because all of that fluid could also impede blood flow, and it's affecting a lot of different things in our body as well. Infections can affect how a wound heals, right? It will prolong it if that wound becomes infected. How much is the bleeding? If it becomes necrotic, if there's too much pressure or too much lack of perfusion getting to tissues, it will die. And those are the types of things that we're thinking about when we're talking about what affects wound healing. So, like I said, I've never really been asked about the types of wound healing. But what I do want to say about dehiscence and evisceration is that dehiscence and evisceration is more, let's just say, someone who has a surgery. Okay. And let's just say someone has a surgery and they have a abdominal surgery of some sort. Okay. Dehiscence is when let's just say you have a surgical wound on your stomach, right? Where you have all your intestines, right? And they stitched it up and the stitch opens and you could see the intestine. That's dehiscence. Evisceration is when the wound actually protrudes through that what's that word? Through the wound. So now you can actually see the intestines. And if you look it up, it's could be quite disturbing, but that's something that you'll see. If you see a wound pop out of the stomach, the first thing you're going to do is call for help. That's the first thing that you do as a nurse. And second thing that you do is you want to cover the wound with a sterile gauze. Sterile, has to be sterile gauze. And then you want to monitor their vitals. But the priority is calling for help, okay, in that situation if the wound protrudes. You're not going to try to shove it back in. Another thing when it comes to wounds, a surgical wound, right? Do not change the first dressing of a surgical wound. That is always the surgeon. The surgeon must change the first dressing. After that, they'll tell you what to do, but that first dressing, you do not touch. That I'm 99% sure that's going to be on your exam because those were on my exam. Okay. Signs of infection. They're going to ask you that. What are they? Well, they're usually called the cardinal signs because they're the cardinal signs of inflammation. Infection usually shows inflammatory response, right? Because when your body goes underneath stress, stress is anything that causes your body upset, such as a cut, you'll get an inflammatory response, which is always redness, or sometimes referred to as arrhythmia, pain, swelling or edema, heat or warmth. They can be used interchangeably. Loss of function, another fancy word for that could be numbness or parasynesthesia, which means numbness, but it's just another way of saying it. I tell you that because they might not say redness and they might not say swelling, they might say edema. So I'm giving you different terms that they might ask you. So, right? If my patient comes into the hospital and they have a wound, what am I looking for? How is it healing? Is there redness around the site now? That can mean infection. Is there pus coming out of the site? Infection. Same thing, regardless of the wound. If it's not a stitch wound like this and it's a wound covered with those dressings, right? Is it red, right? Or is it red yellow? What is the color of the drainage that's coming out of my wound, okay? And I already mentioned this to you, dehiscence and evisceration. So I told you the important nursing management. The bottom picture is an example of evisceration, and the top one is more of dehiscence, okay? So, here's some other things, right? Redness, we could start doing things to protect that can mean it's okay if it's red originally, but let's just say it wasn't red or the redness goes down and then redness appears again. That could be an inflammatory or infection response. Yellow, depending on what's going on, it could be okay, but it could also mean infection. Black could mean necrotic. Okay, if there's black around the wound, not good. We might have to do debridement, which is a procedure where you like remove that the dead tissue. So I already talked about this a little bit with what to do. Like I said, sterile, you call for help for evisceration, you put a sterile gauze on top of it, and you monitor vitals. But the first answer you're going to pick, if it says a priority, you're going to call for help. Okay. I already talked about pressure injuries, what they are, what can they be caused by. Also, decreased mental status. That's also because, right, if this is someone who is confused, comatose, they're not alert and oriented, they might not move as much. That also puts them at a risk for pressure injuries. Okay. As well as we talked about why advanced age can do that, right? They don't have the same skin elasticity and collagen that we have. So bony prominences, the back of the head, the shoulders, your elbows, your knees, your hips, things like that, your ankles, okay, the back of your heel, all of that. Okay. Another thing is that friction. We don't want, if we're going to move a patient, we want to lift them with the sheet. We don't want to drag them, because if you're dragging them, right, you can cause a friction rub. So you don't want to do that. See, here it is. You pull up with it, you don't drag. So I'm just telling you things that I've seen on my exams. As well, like I said, we talked about pads, right? Different pillows that you could put underneath if they have like a pressure injury already. Now we have a Braden scale. What I want you to know about this, that's the most important one they're going to ask you, okay? If it's less than 18, they're at risk for a pressure injury. If it's less than 18, they're at risk for a pressure injury. If it's greater than 18, that means they're not at risk for a pressure injury. That's what I want you to know about the Braden scale. All you need to know about that, okay? And it basically tells you your risk. So someone who's post-operative, who is a surgical patient, who is older, who has an immobile lifestyle, who doesn't eat much, who's malnourished, all of those patients would have a lower Braden scale compared to someone who ambulates or walks, right? 24 hours or even sooner than that from a surgery, who has an active lifestyle, right? Who isn't of an older age, that doesn't have comorbidities, things like that. I don't know what Norton's pressure scale is. Never heard of it. I've only heard of Braden scale. That's why I'm mentioning that to you. Okay. We talked about all of these already, so I'm not going to get into it. Just here's images, right? Stage 1, still intact skin, right? Stage 2, we talked about seeing the dermis. Stage 3, we're talking about getting into the fat. Stage 4, we're talking about now, and even in addition to fat, we're seeing bones, muscle, tendons, ligaments, slaw, and eschar. Slaw and eschar always means that if it says that in the question, it always means it's a worse pressure injury. If it says you see muscle and bone, you always got to think stage 4. If there's too much eschar, too much slaw, might be unstageable, okay? This is eschar. Remember, deep tissue injury could be intact or non-intact. Usually has a purple reddish color. That's how they'll let you know. It's like a purple maroon color. You'll know that's deep tissue injury. And also, hint, whatever diagrams they show you in here are usually the diagrams that they use on your exams if they're going to use them. So know them. This could be a cute thing to look over to know the signs. Okay. Something else for pressure injuries, you want to know the size, the depth of the wounds, right? How deep does it go? And there's ways to measure that. So you'll take like a little measuring tape, right? And you're going to do the head to toe length, so left to right and up and down, okay? And that's something I do see that you always, even if you don't know and you're trying to pick an answer for like a select all that apply or something, I would just pick, okay, like I know that I should know, how deep this wound is, right? What's the centimeters of this wound? What are the characteristics of the wounds? Like all of that stuff, you should know that. I've never seen them do tunneling, which so I'm not really sure what that is. I'm not going to get into that because I just don't know and I don't want to say anything that's wrong with that. But like I said, so when you're doing your wound care, after you do it, you follow the provider's orders, right? You measure it. After you measure it and you get the wounds, you're going to, it looks like, sign with your initials and date it when you did that. Even when you're a nurse, you're going to document when you did this, how you did the care. And even when you do wound care and you finish, you should document like on it, like write it on whatever type of wound it is, doesn't matter. Get like a little sticky thing like this. That's what it's showing you to make sure that you've shown that you did the wound care. So you're going to initial it and date it. And that lets them know, okay, you changed this person's wound dressing on this day at this time. Okay. So another thing is wound drainage. It's something else that you want to know. Characteristics of the wound, right? So serosanguinous and sanguinous. What I want to sanguinous is red blood. Serosanguinous is like a pinkish color. Serous is like a yellow color, but it's not as thick as purulent. Purulent is yellow but thick. That's usually a sign of infection. Now, post-operatively, you would expect sanguinous, and then as the days progress to go to serosanguinous, vice versa, right? You expect it to get lighter. If not, that's a problem. So, smell, if it's odorous as well, it shouldn't be. That could be a sign of infection. So, the first one is serous. The second one is serosanguinous. The third one would be an example of sanguinous, and the last one is purulent. You see, that's the different types. I've never heard of seropurulent. Okay, I just know serosanguinous, serosanguinous, and purulent. Those are the ones I typically see asked. Okay, and I already talked about what they are, so I'm not gonna really get into this too much. This is just repeating it. I've never, like I said, those are a lot of terms I haven't seen. I just know those four, and those are the only four I've ever been tested on in terms of all of my prep in school. Okay, we talked about what would be an infection, right? Those cardinal signs, as well as an odor. And wound, we talked about dehiscence and evisceration, so I'm not going to get into that. Wound culture, it's almost like a side swipe, right? I've never seen them ask about the process of it, just that if it's infected, that you want to get a wound culture, right? So you could determine what sort of infection it is, if there is one, right? Especially if you're seeing that purulent yellow thing, you're going to let the doctor know. They'll order a wound culture specimen so you could, figure out what's going on in there. For pressure injuries, always you want to clean it with the dressings, have a new gauze, wipe it top to bottom. You always want to go, you don't want to bring stuff into the wound, you want to remove it. So when you're like cleaning it, you want to start from where it is and move it outward. You don't want to start outward and go in, okay? Because you can bring an infection into the wound. You could use normal saline to clean it because there's nothing in it. It's like sterile. And a dry gauze, dry sponge area to help it. That's like if when you do lab for therapeutic, you'll do the sterile like dressing chains. That kind of gives you an idea of like the wet to dry change as well, like what you're going to be doing when you're doing wound care, how to clean it. So yeah, like I said, if you're gonna do it, you don't want to go from out to in, you want to go from in to out. And when you clean the wound, you just kind of want to go down it once, right? You don't want to like keep going down it because you're going to put the infection. You're going to wipe it down, like discard it sort of thing. And you'll see this in lab. They're going to do this for skills for you. So it'll make a lot of sense. But yeah, there's different things that you can do. Like I said, we talked about, our goal is to protect them from injury, protect them from harm, and, figure out appropriate measures. As I said, if we see necrosis, we might be thinking about debridement and things like that. But we want to do the best that we can for our patient based on what we have. I've never been asked about the different types of dressings, like tested wise. Like I haven't been asked what types of dressings, but these are good to know. Like the clear you'll typically see on an IV line. Why? Well, it's an IV line. We have risk for phlebitis or extravasation, which means it could lead to necrosis, and phlebitis is inflammation at the site. If you have a dressing like the top one where it's white and it covers it, you might not be able to see that. So that's why we want a translucent dressing for someone who has an IV, and that comes in an IV kit. It's not like you have to figure it out. Okay. I have no idea about the different types of band-aids. I've never been asked about them, but I've seen the roller band-aids for like when you get blood drawn, but I've never been asked about any of these. Okay. So you have an abdominal binder. The one I want to point out over here in the bottom left is like with a Jackson Pratt. So a Jackson Pratt is a compression device that drains things from a surgery. So you have to compress it, meaning press on that little bulb in order to get the drainage from it, as well as you need to compress it to empty it and compress it to close it. So the stuff is going to drain into this Jackson Pratt, but if you want to, it's going to like they're going to ask you how do you like use a Jackson Pratt. You have to compress it to get rid of it and compress it to close it again. Those are the two things. It's always with compression. Just remember with Jackson Pratts, I need to compress it to drain it and compress it to close it. Binders like a sling. I'm not sure what a T binder is, so I'm not gonna really get into that. I'm not like I said, I'm not gonna get into what I don't know, what I do know. Jackson Pratt. Very important. They ask about that. Sometimes they call it a JP. As I said, you need to compress it to open it and to pour it out and compress it to close it. That's the main thing for this. Okay. And it goes with everything else. You need to know, right? What is the dressing? Like, what is not the dressing, what does the wound site look like, right? What kind of wound characteristics, such as what color of fluid am I seeing going into that Jackson Pratt? Just this is different things, right? Home care teaching, right? Do they have the supplies? You want to make sure before your patient goes home, even if you can't figure out, you don't have to memorize everything, but it's like thinking about what should my patient go home with if they have a wound? I should make sure they have the supplies, that they have the education, how to prevent infections, right? What they should look for, when they should notify the provider, right? If they see signs of infection, those cardinal signs, right? They need to eat and walk. That's going to help with wound healing, okay? You're going to do an assessment, right? Because this is where physical assessment comes in. Labs, leukocytes, meaning WBC is elevated, is a sign of infection. Hemoglobin being low. Hemoglobin's normally like 12 to 18, 12 to 16 for females, and like 14 to 18 to men. It depends. Every textbook has a little different. But for hemoglobin, if it's low, that means that they're bleeding. So those are things that we want to look at. Coagulation. Are they able to clot? Are they able to clot themselves to stop the bleeding? Culture and sensitivity. That means you're detecting and looking for bacteria and things. Okay. So we already talked about this. Nursing diagnoses are the things that you would expect to see related to the skin, right? Risk for impaired skin integrity related to immobility, evidenced by patients on bed rest post-operatively. That's an example of a nursing diagnosis, the reason and why. Impaired skin integrity, right? Let's just say they have a pressure injury. You could use that, as well as impaired tissue integrity. Risk for infection related to post-operative patient or post-op, let's just say ileotomy, which is like when you remove a part of the ileum of the intestine, right? They're at risk for infection because they just had a surgery. Acute pain, always, because the wound. They're likely to have pain. And even if you didn't know, you can rule out which nursing diagnosis would be most prominent based on the situation. If we're talking about a wound, we're looking for something that has to do with skin or pain. Anything else really wouldn't make sense, right? So using that nursing process, right, when we're making goals, such as say our nursing diagnosis was impaired skin integrity, our goal would be, okay, the wound will heal by June 1st, right? 2024. That's something, or it decreases in size from 5 centimeters to 2 centimeters by such and such time. So this is just telling you how to use the nursing process in terms of a nursing diagnosis. Okay. I'm not gonna, you get the idea. Skin hygiene, avoiding trauma, good nutrition, looking at yourself all the time, right? Pressure injuries, always, right? Minimizing pressure. If they have them, we were talking about you have to eliminate sport as well as turn them every 2 hours. Maybe devices to minimize pressure. Move. We talk about immobility. They got to keep moving. Reposition. This is what you're going to see all the time. 2 hours. Always talked about with pressure injuries. Dressing changes as orders, movement, but it's always moving, and making sure we move them as a nurse every 2 hours. Okay. Like I said, you're gonna go into the different things in lab, so I'm not gonna get into that. Okay. I just wanted to say that heat causes vasodilation, means vessels open. Okay. This is not as good as something for inflammation. If they have an inflammatory response, we're not going to give them heat because it's going to make it worse because it causes inflammation. Whereas cold reduces inflammation. So we would use cold more or less for an inflamed situation. There's different ways you could use heating pads. You could use them for like pain and things like that, but I wouldn't get, too crazy with it. Cold, just know that cold, like, it can constrict blood vessels. So you're not going to use cold for someone who has a pressure injury. That's just not going to make sense. It's going to cause reduced blood flow, right? But heat would be good because it would open the vessels and promote blood flow. And here you could definitely read this chart when you use ice, when you use heat. But if a patient says, hey, something works for them and it's like an acute pain, let them do that. If it's not, something that's going to cause them any more harm, you have to also go by what the patient wants to. Okay, I think that's it. Okay. Let me just